So my task today is to talk on HBV, functional HBV cure pipeline and clinical data. And these are my disclosures. I want to start with how it started, this issue of functional hepatitis B cure. Almost 10 years ago, there was a meeting of interest groups dealing with hepatitis B, and the issue was hepatitis treatment endpoints workshop. This was a workshop on hepatitis treatment endpoints in the USA, and invite people who were regulatory agencies such as FDA, European Medicines Agency, biopharmaceutical companies, biotechnology companies, and of course, academia. And almost 90% of the survey responders selected functional cure as the goal for new HBV therapies. Now, why not sterilizing cure, for example, but functional cure? Because sterilizing cure, and there's recent issue of nomenclature in terms of sterilizing cure versus sterilizing complete cure versus complete cure. But if you take it like this, sterilizing cure is surface antigen positive, HBV DNA negative, there's no cccDNA, there's no integrated DNA. And basically, there's no active liver disease, no risk of viral recurrence, no risk of HCC, and you don't need to screen for patients. But this is almost like science fiction. Now, if you have no integrated DNA, but the rest is there, so you have cccDNA and surface antigens, DNA is negative, then we can, this is called complete cure. But I mean, there's mixing of these definitions. What about functional cure? Functional cure is a patient who is surface antigen negative, HBV DNA negative, but continues to have cccDNA in the liver, and integrated DNA is present as well. So there's no active liver disease, but there is a risk of viral recurrence, there is a risk of HCC development, so there's definitely a need for HCC screening. Partial cure is the current status. You have patients who are HBV DNA negative through nucleoside analog treatment in general, but they continue to be surface antigen positive. cccDNA is present, integrated DNA is present. There's no active liver disease, but the risk of viral recurrence is there, and this risk is higher compared to patients who have functional cure. Now, I want to go a little bit back, because speaking about functional cure, we have to see what we had, we don't use, what we had today, what we still have today, but did not use and do not use. And I want to start with lamivudine-induced e-antigen seroconversion versus interferon alpha-induced seroconversion in patients with e-antigen positive chronic hepatitis B. Once you have seroconversion, the cumulative rate of relapse in patients who had achieved e-antigen seroconversion is less in interferon-treated patients compared to lamivudine-treated patients. And basically, interferon is better in terms of keeping e-antigen seroconversion alive. And these patients will eventually go on to develop functional cure. If you look at the situation in e-antigen negative chronic hepatitis B, which is currently the big bulk of patients with chronic hepatitis B, the situation is much more evident. In e-antigen negative patients, you have 4% surface antigen clearance at 1 year with interferon, and less than 1% with nucleoside analogs. And this is actually an overestimation, because the nucleoside analog treatment is less than 1%, not only after 1 year, but also after 4 or 5 years, it's not changing. So it's very, very low. So obtaining functional cure in chronic hepatitis B can be done in two ways. The conservative approaches with current drugs and the radical approaches with new drugs. The conservative approach, functional cure with current drugs, PEG interferon alpha and nucleoside analog discontinuation. These are the two ways of getting functional cure. And functional cure through PEG interferon alpha can be done, but since interferon is basically not available anymore, there's no advertisement of drug companies for doctors, and doctors I have to say, rely very much on drug companies, on how to treat their patients. It is a pity that we don't use and we cannot use interferon anymore because it's not available. In Turkey, we're looking for interferon since, I would say, 2 years now, and it's not available. It's available, but it's not. Even in Germany, it's not available, more or less. But if you look, for example, this was a study in 2011 by a Dutch group, and they found that life without interferon is nice, but no side effects to cope with. But it leads to, you need an average of 39 years to clear surface antigen. And in another study, this years of length of treatment is actually higher. But please check, look, if you have high LT, you need 43 years, and if you have low LT, you need less than that, 30 years. Why is that so? Actually, you would expect that with high LT, you would need less because immunological approach would lead to surface antigen decrease and lead to surface antigen clearance. The reason for that is probably that you have these inactive carriers here who contribute to shorter, without interferon, shorter duration of surface antigen positivity. Now, treatment with interferons in the area of interferon, E-antigen-negative chronic hepatitis B. This was a pivotal study published in the New England Journal of Medicine, and 20% of patients had an HBV DNA of less than 400 copies per ml at 6 months post-treatment, so treatment-free follow-up. So this is around 80 international units per ml, so quite low DNA. And this occurred in around 20% of patients. Now, if you follow these patients long-term, you have seen that almost 65% lost surface antigen and cleared surface antigen, thus developed functional cure. For functional cure, you don't have to have surface antibody positivity. It may also be evolved, but you don't need that. And this overall, it's 12% of the whole hepatitis B population you're dealing with. And if you wait longer in this group, the proportion of patients who clear surface antigen may increase as well. Now, so this sets the stage for new drugs. I mean, a new drug which makes sense in terms of surface antigen clearance should have a clearance rate of more than 10% at least to provide something new. And I want to mention again the inactive carrier state, which doesn't need treatment according to current guidelines with reservations, as the previous speaker has alluded to you. In Europe, these patients are patients who have a quantity surface antigen level of less than 1,000 international per ml. So they have low surface antigen levels to start with, and these are very nice. These are very good candidates for new treatments or other treatments as well. And I just want to mention a paper, an oral presentation of at the last EASL meeting, where a Chinese group mentioned a multi-center study of functional cure for inactive hepatitis B surface antigen carriers in China. The ECure study, and they present their interim analysis of their study. Now, this is not the first study. They have published similar studies along the way since 5-10 years around. And the lower the surface antigen to start with, the higher the clearance rate. And so the problem is probably the fear of interferon, pegylated interferon. So do we have what we need is an interferon which has no side effects. Do we have that? But before that, functional cure by discontinuation of nuclear analogs. Now, this is very nicely explained, very nicely done through multi-center studies in hepatitis B, E-antigen-negative chronic hepatitis B patients. By the multivariate competing regression analysis, surface antigen clearance rate was 7 times higher in whites versus Asians by multivariate analysis, and 22 times higher among patients with surface antigen less than 100 international units per ml compared to patients more than 100 international units per ml. Of course, 100 is very low. It sounds nice, but it's unrealistic to look at these numbers. Overall cumulative surface and less probability. Okay. Now, what should we do in terms of viral discontinuation? Should we engage in patient? The patient is happy while putting the patient in risk of developing an active liver disease again. So, but if the patient wants to clear surface antigen, what we have to do is check for ethnicity and surface antigen levels, quantitative surface antigen levels. In Romania, can you do quantitative surface antigen levels at the not private lab level, but in terms of state hospital or university hospital level? Can you check for quantitative surface antigen levels in Romania? Yes or no? Yes? In Turkey, we cannot. In Turkey, it's not possible. And I think if you want to engage in patients in a patient where you consider finite treatment duration, you should not start treating this patient without checking quantitative surface antigen levels, because quantitative surface antigen levels is a must. I'm not talking about correlated antigen or something like that, but you should at least do quantitative surface antigen levels. So what you can do in Europe is, if you have end of therapy surface antigen levels of 1,000 international units per ml, which means that this patient is on nucleoside therapy and you want to discontinue treatment, and at the time of discontinuation, the patient should check for surface antigen levels. And if the patient has less than 1,000 international units per ml, the likelihood of 4-year off-therapy surface antigen loss probability is 41%. So almost half of the patients will lose surface antigen. And that makes sense, and you can stop treatment if the patient doesn't have cirrhosis. In Asia, the same holds true when you have surface antigen levels of less than 100 units. And here, even the surface antigen level is much lower. The 4-year probability is only 33%. But this is a way how you can stop treatment. Now, is this really an issue of race, or is there a viral factor involved? The answer is surface antigen level is surface antigen core antigen level has by multivariate analysis a higher rate of significant hazard ratio of developing surface antigen loss, and age is also involved in non-Asian ethnicity. But if you check for genotype A and B, D are much higher in terms of surface losing compared to genotypes C, B, and C. B and C is in the Far East, A and B is in Europe. So it could be race, it could be viral genotype, it could be both. How about incidence of hepatic decompensation after nucleoside withdrawal? Are we doing any harm to the patients? If you are careful and are adherent to the recommendations made in terms of nucleoside discontinuation, you wouldn't engage in such problems, because what we do is take into perspective a patient who we consider to discontinue surface and nucleoside treatment. The patient has to have non-cirrhotic chronic hepatitis B to start with nucleoside treatment. And after 5 years or so, we stop treatment, this 5-year treatment. It is very unlikely that the patient is going to have advanced liver disease from baseline to end of treatment. So there should be no risk of hepatic decompensation. Only in patients with hepatic decompensation or very severe liver disease is the risk there. And if you look limited sustained remission after nucleoside withdrawal, this is all not paying careful attention to the suggestions made. Because what I showed you in terms of viral genotype and Europe versus Asians, if you pay attention, that patient is not non-cirrhotic. If the patient has less than 1,000 units per ml, you would not have these problems. Now, coming to the radical approach. Radical approach is new treatments. And for new treatments, we have the luxury of using also new biotechnologies, not only better assessment of new treatment options, but of use of new biotechnology, such as gene silencing through antisense oligonucleotides or small interfering RNA, or even CRISPR technology, cutting of genes. But so far we are using antisense gene silencing through antisense oligonucleotides or small interfering RNA. That has also been done in the COVID pandemics with the vaccine story. The main target in functional cures for new compounds is surface antigen, of course, and the drug pipeline potential for combination therapy to cure is replication inhibition, and entry inhibitors such as bulevirtide and others. I have to tell you that bulevirtide is the success story after the surface antigen entry receptor has been found, the NTCP, and sodium taurochol polypeptide. And this made it made also the journal very famous, the eLife journal, which nobody knew before, became famous after NTCP. But even there, we don't know if there is a difference between HBV and HDV. There should be no difference, because even Delta virus used the large surface antigen to enter the cell, but there has to be a difference because some compounds work better in Delta compared to B and vice versa. So we don't know exactly what happens how the HBV or Delta virus enters the cell. Yes, they use the NTCP receptor, but there's the hypersulfan glucoprotein before, and then other things. So even there, we don't know everything. And then we have nucleoside analogs, the NTK, tenofovir, the TAF, and novel nucleoside analogs, very potent nucleoside analogs. Supernucleoside analogs are also considering. The capsid assembly modulators. You see a lot of these capsid assembly modulators. Most of them are now in the science garbage because they don't brought what scientists had expected. They brought low levels of HBV DNA. Maybe they were more effective than currently used nucleosides in terms of bringing the HBV DNA down. But in terms of surface antigen levels, they didn't brought at least surface antigen clearance or off-treatment surface antigen clearance in particular. And in that sense, there's now a new hope with the capsid assembly modulators, which may be functioning through an aggregate and through an immunologic pathway. But we have to wait and see for these new compounds. Nucleoside polymers, I will mention about this. Small interfering RNA and antisense oligonucleotides, I will mention them. RNA discipliners. Okay. But let's talk also about immune stimulation. In terms of innate immunity, toll-like receptor 7 and 8 receptor agonists. These are very good examples of pattern recognition receptors, so an effect on innate immunity. There's definitely an effect on innate immunity there, but without clinical consequence. So it doesn't transform into normalization of ALT, normal HBV DNA decrease, and so on. So immunological approaches appear to be so far unsuccessful. Immune checkpoint inhibitors like nivolumab and anti-PD-L1 other compounds. There is hope for there, but you have to also consider that they may be associated with clinical consequences, side effects, such as autoimmune hepatitis, like pictures and so on. Therapeutic vaccines are in general so far not very successful, but then we have this HBs immunoglobulins, anti-HBs, and we have that for so many years. But now we have the super anti-HBs immunoglobulins, and they appear to be effective in term, not through passive immunization, but they may lead to active immunological efficacy and be effective. Now, I will. If you look in the HBV life cycle, I've mentioned that receptor binding is not. I mean, parts of the story is solved, but not all of it, and we don't know. There are things which we don't know exactly. For example, how endocytosis occurs, how it's uncoated and transported to the nucleus, and then how the relaxed circular DNA is converted to cccDNA, the mini chromosome. Epigenetic issues are important, such as DNA methylation or histone methylation or acetylation, and there may be a new. I mean, I'm not going to talk about any drugs which is not used in, which is used only at the preclinical stage, but in terms of epigenetic control, there may be in the years to come, not long far away, the first clinical studies with humans. And this would be in the context of cccDNA decrease. But we have to wait and see if that's going to happen. And that's going to be through use of the CRISPR technology. But in terms of transcription inhibitors, using small interfering RNA and unsensible nucleotides, a lot of has been achieved. Capsid assembly modulators, I have mentioned, so far not effective, but there's a new compound which may be effective. And then we have prevention of viral extrusion through nucleus polymers. In terms of entry inhibitors, I am going not to mention not bepirovirsen, bulvartide, because it's in delta hepatitis. Yes, bulvartide is effective in delta hepatitis. Why do we not use it in hepatitis B? Because it's an entry inhibitor. It should work. Because it's not as effective as in delta hepatitis. That's the reason. And there's a new compound by a drug company which is going to be in phase 2 studies in delta hepatitis and another entry inhibitor. And we'll see if that is going to change the issue in terms of surface antigen reduction. Because when bulvartide was first introduced, the first thing which we'd look for was surface antigen levels, and nothing changed, of course, with monotherapy. So we'll see if the new compound is going to change anything. Now, this GNG compounds GNGs has left the field because of flares, of the fear of flares, but they used a capsid assembly modulator, and there was a decrease of surface antigen level, but after stopping treatment, it went up again. Now, I just want to mention this study because this study is using a small interfering RNA called xalnasiran I think in hepatitis B, and they used it with an immunomodulated toll receptor-like agonist, and they compared it with PEG interferon to see if the toll-like receptor agonist is equally effective or more effective than the PEG interferon. And what happened, this is the study outline, but I just want to show you this result. The gray line here is end of treatment, and let's see. I mean, the mild gray line is the end of treatment, and the dark gray line is the post-treatment response. And as you can see, with toll-like receptor 7 agonist, there is some response, but it's not as good as with peg interferon alpha. And that's a problem, because we want to get rid of interferon, but it's still there. And I just want to mention a new compound, which is like interferon. It's a peg interferon, but it has no side effects. And this shows that lonofarin peg interferon lambda program was purchased by a group called Eiger Immunotherapeutics. Now this peg interferon lambda was actually used in delta hepatitis. And the reason for it's not no longer availability was because it led to 4 serious side adverse events. 4 patients had developed decompensation. And I'm telling you that this patient, this drug is a compound interferon which has no side effects. So what's the paradox here? It may be that the interferon was so effective that it led to an immunological response which led to decompensation in patients who had low liver reserve. So these patients who had cirrhosis with high portal pressure. So these were not the good candidates, and that made this study unfortunately lead to failure of the study. But anyway, another compound is the Vir compound. I just want to mention a few studies. I know I'm out of time, but this is a small interfering RNA compound with a combination of anti-HBs compound. And this is a hope for new treatment in terms of hepatitis B as well as for delta hepatitis. And here the issue is that through this super antibody, it can lead to surface antigen level decreases. And this decrease in surface antigen levels would lead to reversal of the exhaustion of the immune system and would pave the way to have an immune control back and further leading to surface antigen decrease through the reawakened immune system. And that's also the case with other super hepatitis B antibodies. But here, what you can see is that in hepatitis B, so these 2 compounds versus plus peg interferon. And as you can see, at the end of treatment, there was some patients who cleared surface antigen levels, 15% cleared surface antigen levels. It's in the middle section here. But after stopping treatment, off treatment, there was no, these surface antigen negative patients came back as positive. But with peg interferon, this was prevented. And furthermore, anti-HBs response was seen in patients, around 50% of patients who were on peg interferon therapy at the end of treatment. I mean, if you look here, you have 55 plus 15, or 66 plus 14, 17, 70, more than 7, almost 80% of patients had very low levels of surface antigen, very low levels, and in a lot of patients, antibody developed, and this was sustained in some patients after stopping treatment. You may have increased the number of patients who had surface antibody positivity or surface antigen negativity by having intervened with injections, with anti-HBs injections. But this was not the case, of course. The same holds true for delta hepatitis, but here they decided to have a phase 3 study based on the studies which in phase 2 studies to have a phase 2 study, and this phase 3 study is already finished enrollment, but without peg interferon. Another is the BJT, another compound from Novotech Pharmaceuticals. It's again an anti-HBs, and they decided on a phase 3 study based on their study, based on the results of the phase 2 studies, based on just on the super anti-HBs, without an addition of small interfering RNA. Finally, I just want to mention that bepirovirsen is going to be the first drug, probably small interfering RNA molecule, antisense oligonucleotide molecule, which has an effect on surface antigen levels. But it's a weak effect. It's not very convincing. And most of the patients who have a little bit higher surface antigen levels, they have a decrease of surface antigen levels throughout the treatment, but then go up again. And only patients who have less than 3,000 international units, and in particular less than 1,000 international units, have around 20% of response. And it is expected that they will get FDA approval by the end of 2026. So I'm going to finish here. And despite the fact that you can decrease post-treatment relapse by adding PEG interferon, but they didn't want to go into that. And finally, the nucleic acid polymer story is a long story. I can tell you if there's a question I'm going to ask. But in summary, current treatment of HBV aiming is very effective in all patients, basically. The problem is the indefinite treatment duration. And yes, we have cheaper drugs, but still, in the past, nobody would pay out of their pocket, but now in Turkey, most patients have to pay out of their pocket, at least some of the drugs, and that's a problem. Functional cure surface antigen clearance is therefore attractive because it needs shorter treatment duration. It can be done with nucleotide analog discontinuation or with interferons. With regard to neutral treatment, we have small interfering RNA antisense oligonucleotides with immunomodulator. But combination with immunomodulator drugs is needed still, because that's the best way of getting rid of the disease. And the best one is an old drug, pegylated interferon. Monoclonal antibodies against surface antigen as immunomodulators provides a new hope, and that's the end of my story. Okay, thank you very much. I'm sorry for long.